So today we are going to discuss about CO-RADS. CO-RADS is nothing but COVID-19 reporting and data system. So this is similar to other reporting and data system like that of liver imaging and reporting and data system. Then we have breast imaging, reporting and data system, and there is PI-RADS, prostate, and various other imaging. The why we have come up with this reporting and data system. To understand this first we need to know what are the typical features that we see in a COVID patient. Now, if we consider a lung, we always knew that the COVID was predominantly affecting the basal segment and involving the peripheral part of the lung. It was involving mainly the peripheral part of the lung. It was involving the basal segment. There were ground glass opacities on CT, and there were consolidations on X-ray and CT, and these were mainly in the peripheral, and they are multifocal and always bilateral. Most of the time bilateral. So bilateral, multifocal. Okay, bilateral and multifocal. But what in the recent one, when they studied multiple images, what they have realized is that the involvement of the basal segment was not consistent in all the patients. There are some patients where frequently they were finding the lesions even in the apical segment without any gradient. So that part was removed. The basal predominant was removed from the CO-RADS because it is not consistent with a COVID patient. Now, what are the other features that were consistent? That is, one is ground glass opacity, consolidation, bilateral and multifocal, and these lesions were in the peripheral. Predominantly where these lesions were in the periphery, these lesions were along the visceral pleura. Now, why do I say along the visceral pleura? Because not only it was present in the subpleural location, but also these lesions were present along the fissures. So these lesions are present along the fissures. So there is multifocal lesion which is present along the fissures and along the pleural surface, with no basal predominance. Basal predominance can be an additional feature, but this is not a typical feature that we see in the CO-RADS. So that is very important thing that we need to know. So we understood what are the typical features. Now again, these typical features are divided into obligatory features and confirmatory features. Now, as I told, the ground glass opacities, the consolidations, which are predominant to visceral surface, which are multifocal and bilateral, these are the obligatory features. These are the features that must be present to tell it is a COVID-19. Now, what are the confirmatory features? Now, whenever we see a ground glass opacity, it might be a sharply demarcated, or it might be partially unsharp margins. It might be with an unsharp margin. So they say unsharp demarcation is slightly more typical of the COVID-19. Also, there will be sometimes the pleural thickening with which will look like a crazy paving pattern that we see. Crazy paving is nothing but a ground glass opacity with the septal thickening, not the pleural thickening, sorry. It's the septal thickening that we see along with the ground glass opacity. Now what we see is this crazy paving pattern. Now that if it is present, then it is a typical confirmatory feature. But mind you, there is one thing that we should always exclude is the pleural effusion. If there is pleural effusion, now this can be this ground glass opacity, this septal thickening, and this pleural effusion. A combination of these three might tell that there is cardiogenic edema or the pulmonary edema, which is responsible for crazy paving along with pleural effusion. So we should always exclude the pleural effusion. And also, the CO-RADS is done only for pulmonary disease of COVID, not the COVID affecting the heart. If the COVID affecting the heart, then we could have included the pleural effusion, which might be a feature of the cardiac involvement, but we will not consider anything other than the lung involvement in CO-RADS. That's why the pleural effusion should be excluded. And then The patterns compatible with organizing pneumonia, specifically peripherally arranged consolidation with peripheral consolidation with central ground glass opacity, classical reverse halo sign. Classical reverse halo sign is what we see. Again, this peripherally located consolidation with central ground glass opacities. Reverse halo sign is what we see mainly in organizing pneumonia. The similar picture can be seen in case of COVID, so that is a confirmatory feature. The very important feature is when we see any lesion in a CORADS in a COVID patient. Now we can see some thickened blood vessel in the parenchyma near that region. This is one more confirmatory feature. So if these confirmatory features are there, which is multifocal, bilateral, visceral predominance with crazy paving pattern or organizing pneumonia pattern, along with thick vessels within the parenchyma, we say this is COVID-19. And now what grade that we give for this is CORADS 5. If we say CORADS 5, it is having all the typical features of COVID-19. It's a confirmatory of COVID. Now this is what I have taught in the previous video as well. Now these features, if it is present, is CORADS 5. Now, whatever the feature, if the RT-PCR is positive, if RT-PCR is positive, then it will become CORADS 6. Now this is what we know about the CORADS. Now 5 and 6 is what we know. Now we'll see when do we say CORADS 0, 1, 2, 3 and 4. Now for that, first, what are the CORADS 0? CORADS 0 means that the imaging is not adequate. So if the patient has taken a deep breath or patient has done some sort of movement, so which has distorted the CT image, and then we cannot report that image, that's when we say that this is inadequate, repeat the study. Okay, CORAD 0 tells that I am not going to report this because this is not a good study to be reported. Now so CORAD 0 is excluded, doesn't mean anything, it just tells that I can't report this. Now CORADS 1 is and CORADS 2 are low suspicious towards COVID. Why? Because CORADS 1 means it is a non-infectious condition. It can be fibrosis, it can be the pulmonary edema. So these are the conditions. It can be emphysema, which are nothing to do with infection. But CORADS 2 are the infections. So there might be some tree in bud appearance. There might be some tree in bud appearance. There might be some centrally located. There might be some consolidations which are looking like a bronchopneumonia or a lobar pneumonia. So we know that this is not COVID, this is some other pneumonia the patient is having because of some other organism. Lobar consolidation, bronchopneumonia, all are the features of other infections with stream bud appearance, classical infection with no peripheral multifocal ground glass and consolidation, no typical features of COVID, then we call it as CORADS 2. So CORADS 1 is non-infectious, CORADS 2 is infectious condition which doesn't have any typical feature of COVID-19, then we call it as CORAD 2. Very low. So the non-infectious condition is having very low suspicious of COVID, whereas the CORADS 2, it is an infection again. So even COVID is an infection, so infection can manifest in different way. So sometimes, like, less likely, but there can be some COVID cases which might mimic some infections. So this is also low risk, but rarely it might show some cases. So but non-infectious conditions, CORADS 1 is having the least risk. So that's about CORADS 1 and 2. Now CORADS 3 is when there are features of the COVID-19 plus there is underlying lung is showing some other conditions. So that's when we call it as the CORADS 3. There are features of COVID, there are features of non-COVID, so we don't know what exactly is happening here. So that's when we call it as CORADS 3. So this is again very confusing. We don't know what exactly is happening. So it is equivocal. It can be non-infectious, it can be COVID. So that is a separate category. Now CORADS 4 and 5. The 5, as we told, it's having all the typical features, but the CORAD 4 is now not having all the typical features. For example, we need to have bilateral lesions. Okay, you need to have bilateral lesions for CORAD 5, but here there is a unilateral, and there should be multiple lesions in case of CORAD 5, but here there might be unifocal lesion. There is a requirement of a peripheral, the multifocal involvement. There might be unifocal or there might be diffuse involvement of the disease. In CORADS 5, we told it is peripheral or along the visceral pleura, but here there might be central consolidation. So these are the features which are this, and this central consolidation is not typical of an infection. Infection will have proper peribronchovascular consolidation. If there is not proper peribronchovascular consolidations, then we call it suspicious lesion. So all the features of COVID, but there are few features are not fitting into the typical COVID features. That's when we call it as CORADS 4. Now, why we have to classify all this? Because one of this and the CORAD 6, as I told, is nothing but RT-PCR positive. Now, why we have to do all these things when we why we have to do all these things is very important to understand, because this will give us the risk of the disease. Now whenever there is CORAD 1, the CORADS 1, it is having very low risk, whereas CORADS 2 is having low risk, and equivocal or unsure is when we have CORADS 3, because there will be overlapping of some disease with the features of some disease, other disease like infectious and non-infectious disease with the COVID features. So we are not sure where exactly to put it in. Suspicious lesions are having most of the features of the COVID, but they are not fitting into the typical confirmatory features. Obligatory features are present, but the confirmatory features are not fitting in properly. That's when we call it as CORAD. Why we do all this is because of this one reason. See, whenever we saw a non-infectious lesion, it was only 6% of the cases became the COVID. Out of 100, if you take, only 6 people became COVID positive. So if I give CORADS 1, I can tell that most of the patients will not have COVID at all. But if I say CORADS 2, there is slightly higher chances. But imagine if I have given CORADS 4 or 5, see, more than 50%, more than 80% of the patients are COVID if I give more than CORADS of the 4 or 5. So that is the importance of the scoring. Now the CORADS category 0, as I told, it is incomplete or insufficient quality. The CORAD 1 falls to the negative for pneumonia category. And one more thing we have to understand, that the CORAD 1 doesn't only mean it is non-infectious. It also means if there is a normal patient, then also we put it under CORAD 1. So if there is normal or it is non-infectious, then we put it under CORAD. This is similar to LI-RADS, but this is not similar to BI-RADS. In BI-RADS, if I say 1, that means it is a normal, it's a normal breast. But if I say 2, then it means there is a benign lesion. So that's the difference. But LI-RADS, what it says, if there is a nodule, it might be benign, then it will come under 1, or if there is no lesion at all, normal lung, then also it will come under 1. So whereas there was a lesion, there was no lesion, both comes under 1. Whereas BI-RADS, when there is no lesion, it will come under 1, but when there is lesion, it will go under 2. That's the similarity and difference between the LI-RADS and BI-RADS compared to or CORADS. Now this is a normal appearing lung, so this will fall under CORADS 1. Now, CORADS category 2, as I told, it will have infectious conditions, like it can have bronchitis, bronchiolitis, bronchopneumonia, lobar pneumonia, pulmonary abscess. So bronchitis will have thickening of the bronchioles. Bronchitis and bronchiolitis will have thickening of the bronchioles. Bronchiolitis might have tree in bud appearance, and bronchopneumonia might have multiple patches of consolidations, and lobar pneumonia will have an entire lobe will be consolidation, and there will be pulmonary abscess, there might be a cavity formation. So if in case we see a cavity, we see a tree in bud appearance, we see thickening of the bronchus, we see multifocal consolidations looking like bronchopneumonia or lobar pneumonia, or there is cavitation, then it falls under category 2, typical infectious pattern. This falls under atypical appearance category under RSNA consensus. Just a correlation with RSNA consensus statement. So in this image, we can see that there is tree in bud appearance. We can see some bronchial thickening, also some consolidations. So we can see some consolidations, bronchial thickening, and it is not having multifocal typical like that of COVID. And here again we can see some centrilobular nodules with tree in bud appearance and a lobar consolidation. So these are the typical features of infection which is not COVID-19, as well as it will have features that are not fit. The perihilar lesion, ground glass opacity, can be because of a pulmonary edema. Homogeneous extensive lesion, extensive ground glass opacity can be because of hypersensitivity, pneumonitis, or various other conditions. So these are not typical of COVID-19 features. So this overlapping between two various other diseases. So this is a case where there is unifocal ground glass opacity. So what COVID-RADS says, multifocal, present in the periphery, along the visceral pleura, and it is bilateral involved. So it is only unifocal, one patch of ground glass. You cannot call it as COVID. It can be something else, some other disease as well, but it can it be COVID? Yeah, it can be only the only manifest, the earliest manifestation, or only part involved. Rarely it might happen as well. So that's why we cannot exactly tell whether it is COVID, or we cannot exactly tell whether it is a non-COVID causing this kind of ground glass opacity. Now in this we can see there is extensive ground glass opacity bilateral, but what COVID mainly will have multifocal patchy involvement of ground glass opacity. And now in this what we see, we can see the central consolidations, bilateral central consolidation with extensive ground glass opacities. Again, extensive ground glass opacity will not be a feature in the COVID. With the COVID, there will be multifocal ground glass opacity. So this will not fit into. So this can be some other diseases which can be manifesting in this way. So this does not fit. So that's when we call this. But this is not exactly an infectious condition, so, or not a non-infectious. So we cannot put exactly in which category to put. So that's when we call it as CORAD score, as we told, all the features. It will have COVID category 5 findings, but there may not be contact with the pleural surface, and they may not be along the peribronchovascular as well. They may not be along the peribronch. If it is unilateral peribronchovascular, it can be an infection as well, but it is not unilateral peribronchovascular like infection. It is not along the visceral pleura. And this might be superimposed pre-existing pulmonary abnormalities. Might be some other abnormalities that lung might already be having, so which might make our diagnosis slightly difficult. So what CORAD 4 just tells us is that it is having typical features of CORADs, the most of the typical features, except few findings like along the visceral pleura, or it is not having it is not in the visceral pleura, but it is not strictly along the peribronchovascular and unilateral involvement along the peribronchovascular like that of the CORADs too. So this is when we call it as category 4. It is looking like COVID of COVID-19, but we cannot put in CORADs 5. That's when we put it in 4. This again comes under indeterminate appearance category in RNA consensus statement. And so this is an example. You can see there is multifocal ground glass opacity, but this is only unilateral involvement. This image, if you see, there is extensive emphysematous change, but here there is crazy paving pattern, or the thickening of the septal thickening along with the ground glass opacities. Now this is a case of COVID. Looks like bilateral involvement, ground glass opacity, septal thickening, but underlying emphysematous changes is present in this. So there is some diseases, pre-existing diseases present. So that's when either there is pre-existing disease, or there are some changes which are not fitting in the CORADS 5. That's when we call it as CO-RADS 4. Now going on to the CO-RADS 5 again, which will have all the typical features: ground glass opacities, consolidation along the visceral pleural surface, multifocal subpleural location. So if this is the lung, the lesions will be present along the visceral surface, along the fissures. This will be along the fissures, peripherally located, not present in the central. It can be ground glass, it can be consolidation, it can be ground glass, it can be consolidation, subpleural, multifocal, peripheral, bilateral, ground glass, and with the consolidation. If the consolidation and ground glass both are present, it is having a typical halo sign, that is peripheral consolidation with central ground glass, mainly in the subpleural location, typical of an organizing pneumonia, cryptogenic organizing pneumonia, or the eosinophilic pneumonia. So these are the typical features of the CO-RADS 5. Now again, if you see this, the obligatory features are nothing but the ground glass opacity, consolidation, visceral surface presence, and multifocal and bilateral. Again, crazy paving, organizing pneumonia pattern, and thick vessel within the parenchyma. Very important, thick vessel within the parenchyma confirms of the COVID. Presence of the pleural effusion will exclude the typical COVID lung disease. So these are the features that are typical of the CORADs: multifocal ground glass opacities with thickened blood vessel within the parenchyma. We can see subpleural lesions. Also, we can see subpleural band, a typical case of COVID-19. So this is how we diagnose COVID-19. CORADs category 6. What this tells us is whatever the appearance in HRCT may be, but this given lesion is a COVID-19 lesion. Appearance in HRCT is COVID-19 HRCT. So CORAD 0 is, what does it tell? It tells that this is inadequate study. I cannot report with this. CORAD 1 is either normal or a non-infectious conditions like fibrosis, emphysema, or other conditions. And CORAD 2 is any infectious conditions: bronchitis, bronchiolitis, lobar pneumonia, bronchopneumonia, abscess. CORAD 3 tells us that it may be COVID, or it may not, it may be other conditions, not COVID. Both the features are present, we cannot determine it. CORADS 4 is a suspicious lesion with an underlying previous disease which is present, which is making our diagnosis difficult, or this is having most of the features except that it is not along the visceral, the lesion is not along the visceral surface, and the lesion is not, even though the visual lesion is not in the periphery, it is not in the central along the peribronchovascular. So that is very important. It's not in the periphery, but it is not in the center along the peribronchovascular. If it is in the center, if it is along the peribronchovascular, directly I'll put it under it might be an infectious lesion, or you can put it under the CORADS 2. So it should not be fitting in the CORADS 2, CORADS 1, or CORADS 3. That's when we put, but it looks more like CORADS 5, but we cannot put it in the CORADS 5. That's when we go for CORADS 4. The CORADS 5 is having all the typical features that we say. CORADS 6 doesn't matter what's the picture, RT-PCR positive. Now when I say CORADS 1, it is having low, very low suspicious of COVID-19. CORADS 2 is having low risk. CORADS 3 is equivocal or unsure. CORADS 4 is high, and whereas CORADS 5 is very